I think we need to get started with the next section of the program. For those of you who haven't noticed, the first session today was all MDs. The second session was all PhDs. The MDs got 5 minutes for question. The PhDs don't. They only get 10 minutes to do a presentation. So we have a little bit less time in this section. I also want to mention to people that those little triangular things on your table are microphones. And so if you have questions that you would like to ask during our question and answer period later, you can use those as opposed to necessarily getting up and standing by the microphones in the pack. This session is on clinical and public health laboratory setting, policy, practice, and data. I was interested to see that data came last out of policy and practice. And our first speaker is going to be Chris Petropoulos, who is the Chief Medical Officer at Monogram Biosciences and also the Vice President at LabCorp. Chris.
Uh-oh.
There you go.
Okay. Okay, my disclaimer is that I had actually adhered to the title, so I'm going to be talking about practices, platforms, and challenges. So there is no data in this talk, so for those of you expecting to see some data, we'll have to wait for some other talks in the summit. And I wanted to start out initially by saying a little bit about LabCorp, and I assume most of you in this room know or are familiar with LabCorp, but it's a fairly large company, and actually recently, within the last couple of years, got considerably larger by the acquisition of Covance. So now actually the company sits on both sides of the fence. It's busy providing commercial diagnostic tests for routine clinical practice, but it also is engaged very closely in the development of new drugs and therapeutics, including HCV direct-acting agents. So, and I just wanted to point out that there are a considerable number of laboratories across the U.S. and many patient service centers, and quite an extensive test menu that I can't possibly go through today, but if you imagine a test that's needed to take care of a HCV infected person, I'm sure that LabCorp offers it. And we do handle quite a number of tests every day. And this just gives you some, very quickly, some idea of where we're situated. So obviously the patient service centers are located around the major population centers of the U.S., relatively restricted to the U.S., and you can see that there's a clustering in the Northeast and Florida and California, not surprisingly. We also have esoteric testing, and that's actually how I got involved in LabCorp. So I was at Monogram Biosciences for, actually it's coming up on 20 years, and we were one of the esoteric labs that was acquired by LabCorp. So testing practices, so in HCV and actually in across hepatitis, we have a very broad portfolio. We do serology testing, we do the nucleic acid confirmation testing, we do genotyping and subtyping, viral load, so quantitative RNA tests. We also have assays for the direct-acting agents, resistance to the direct-acting agents, and we also can characterize host factors. And so, again, if you need an assay, it's probably available through LabCorp. I wanted to point out that for HCV testing, we've also developed a number of reflex tests, and I won't go through this whole list, but if you order one test that is likely to be linked to subsequent testing, it's probably available in one of the reflexes. And I would urge all of you to just go to the website, look, just Google LabCorp test menu, and it'll pop up, and you can find a lot of information on what's available, and it's pretty comprehensive. So we can reflex from RNAs to genotypes and antibodies to RNAs, and we also have some more specialty reflexes that relate to some of the treatments we heard earlier this morning, some of the subtleties on testing or treating genotype 1A infected patients. And you're not expected to read this, but you can actually go to the website and you can pull this down. So actually all of these tests are described nicely. And again, if you go to the website, you can pull this material down or you can refer to it later when these slides are posted. But again, the website can be very helpful. As far as testing platforms, we like to think, LabCorp likes to think that we are very platform agnostic, so we have many different types of instruments and platforms available. So you can see that for the various tests that are listed here, there's not just one way of doing things. We probably offer several different testing platforms. I would point out recently we switched to the GenMark e-sensor test for genotyping and subtyping because we felt it better resolved some of the more difficult subtypes that we ran across. And we do offer other tests that people have probably already forgotten, but IL-28B, we were the first lab to launch IL-28B testing. Not so important these days, but a few years ago it was very much in demand. And then I would like to point out FiberSure. So we actually offer the FiberSure assay, which is an assay based on necroinflammatory markers and can be used to gauge the degree of fibrosis and cirrhosis in patients with hepatitis. So. I will also mention that, again, we do have these tests that are a little more complex that are related to detecting resistance-associated variants or polymorphisms, whatever your preference is for referring to these substitutions. Again, the impact of these on treatment is there are some special circumstances, but it's certainly not like the situation we saw in HIV where resistance testing was critically important. And I would mention that we actually do apply next generation sequencing when we do these tests, but we try and mimic what is conventional sequencing sensitivity. So we don't go down to these very low levels where clinical relevance isn't established. We tend to set the sensitivity at something reasonable like 10%. And then we actually have these other tools, and this is, again, you're not meant to read this, but there's a specimen collection guide, so you can go on the website. And depending on the test you order, you can get, based on the test code you want to order, you can go and you can learn a little bit more about what the test will provide you and what type of sample you should collect and what type of volume you should submit. So I'd encourage you all to go and look at that type of information. I did want to mention a little bit about physician and patient education. So we actually do try very hard to develop materials that can help inform and identify and attract new patients and to care and obviously new clinicians to our testing services. So we actually perform a fair amount of routine periodic testing of our sales force. We have an extensive sales force to handle all the accounts, so we actually have specialty accounts that are serviced by highly trained members. We spend a fair amount of time developing medical educational materials, and we actually do programs, so we actually can go out in the field and talk to audiences. And we have a medical science liaison team, so in this team originally was dedicated to HIV, but with the movement of direct-acting agents into the HCV space, those individuals have taken on a broader responsibility and are available. And I would again plug the website. So there's a lot of information on the website. There's the test menu. There are references to any scientific information that's on there, so you can then go to the literature and read more in detail. And then there are direct links to medical educational materials, and I'll just show you a couple of those. And then we also do like to do interesting studies on occasion and get them into conferences and scientific publications. So this is just a piece of a material that we developed, and you can see that there's basically a testing algorithm that guides you through the screening stages and then treatment and what one might do if there was a treatment failure or relapse. So those guides are available. Again, I don't want to go into it in a lot of detail, but they're available on the web. And then we also actually have these other types of materials that we can actually leave with patients or with clinicians. And they do talk about the CDC guidelines and CDC recommendations and baby boomer testing. But they also give a lot of background that the patient can use to learn about HCV and how it's treated. So. Again, this is just another example of the type of material we have. FiberSure may be less, familiar to many folks or patients, and so again, for other related tests, we have these types of materials. And then I'll just close with testing challenges. So one of the things that we've struggled with is that the field is moving so fast that it's hard to keep up with all of the changes and provide services that are needed. And I'll give you some examples. IL-28B, everybody wanted it. Now nobody really wants it. Q80K testing for Semipravir, everybody wanted it. Now nobody wants it. NS5A RAVs, it's got a nice little niche space now. We've got new drugs that have come out where the NS5A testing is not required and not needed. So that just presents challenges with managing the lab and sales forces and personnel. And then resolving indeterminate genotype subtype calls, that's difficult. If you're going to treat based on genotype subtype, it's important to have that, and we can't always get that, even with the new technologies. And I think one of the things we struggle with is gauging future opportunities. So how do you commit resources to develop an assay and then support it when you know that it's likely going to have a limited lifespan? So that's just one of those business challenges. And then the rest of the things on the page, I see I'm out of time here, but they're related to logistics and operations, and that accompanies any testing where the volumes are somewhat unpredictable and changing and in flux. So I'll leave it at that, and I'll go take my seat at the table.
Thanks very much, Chris. We've heard from LabCorp. Now I guess it's time to hear from Quest. Our next speaker will be Rick Pesano, who is the Medical Director for Infectious Diseases at Quest Diagnostics. Rick?
Thanks, Bernie, and thanks, John and Salim, for the invitation. One of the advantages of following Chris, and I've known Chris and worked with him for a long time, is that I don't have to say everything the same. Quest Diagnostics is a very large organization, very analogous in many ways to what LabCorp is. We have about 45,000 individuals in the company, services across the country, and services about half the physicians in the United States. So it's very analogous to a lot of the demographics and information that have already been said. So I'm going to talk a little bit about some of what we've done to implement the guidelines. And it's not without issues that we deal with, and I'm going to bring some of those up, because I think it's good for the discussion going forward. So algorithm, everyone knows, this is an old slide. This is 25 IUs as a cutoff. It's really now 15. So we know that to be true. This guideline is being followed pretty clearly, but we all know that in everything that's been said this morning about having antibody testing alone has always been a challenge to get the patient back in. And I did a lot of HCV care in my clinic. I'm an HIV provider by training, but did a lot of HCV and co-infection work. Getting my patients back in the clinic to do the RNA testing is a challenge. So we looked at, actually just pulled some of this data. It's not surprising if you look at some of the data on antibody positivity alone, just starting to look at that individually. From the non-reflex to the reflex, it was about the same for 5% reactive antibodies. When you get into the era of looking at baby boomers, you can see that there's an increase. And of course, obviously, this is dependent on the population you screen. That's not a surprise. However, you would normally see an increase because it's an at-risk population. One of the things we did look at also is to say and we just pulled this data for 2016, and this is only a snippet. I'll talk a little bit later about the relationship that Quest has with the CDC for looking at our data sets and trying to make sense epidemiologically and whether or not we're making inroads with this algorithm and getting people into testing. So in 2016, I asked the question of my team, of those antibody positives, how many were RNA positive? Because in our organization, one of the things that we did, and believe me, this is not easy, it was a challenge in a large reference lab, we actually turned off testing for antibody as a sole testing offering. So the only test we offer for HCV screening is antibody testing with a reflex for positives to go onto NET. So if you order a test for that, you automatically fall into this reflex category. So essentially 100% of tests that come in for HCV screening and that are antibody positive will go to reflex. So it's not a matter of bringing in the patient for another draw. But what we found is about 50, almost 60% of patients were RNA positive that were antibody positive. This is actually a little bit lower than some of the literature published this year that says it's upwards of 70%. All this says to me is that it's not terribly surprising that individuals who are antibody positive need NAT testing to know whether or not they have a current active infection. It just brings it up. As an obvious, everyone knows this now, but in our system, that is a given to actually get that done. Now, one of the issues we face is that in our organization, a challenge has been dealing with client confusion. We have a lower limit of detection of 15 in our assay using the Roche-Cobas assay. The problem is that sometimes you get a less than 15 in a quant, but you have a detected RNA below 15. This happens. It happens at about 2% of the time. And I will say that our reflex is a quant, not a qual. That's another part of our assay development to say that we didn't want to go with a qual and have to have the system, the healthcare system, go and now repeat a baseline quant. So the reflex automatically goes to quant. So this issue, we get a lot of calls in the lab about, well, you said I'm less than 15, which is non-detected, but you detect a virus. So we actually pulled some samples just to look at them. Remember, the LOD is 15 on the assay, but we went and did TMAs on about 50 positives just to see, because the LOD for a TMA is about 5.8 IUs per ml. And we found, in fact, that about 60 to 70% of those samples were, in fact, repeat positive, but some weren't. So the question that comes up, when you're getting down to the LOD, you know that in a lab, you can repeat a test very close to the LOD, get a positive one day and get a negative the next. So is that assay variation? Is that biologic? Is it real? Is it not? But we do know that, at least in several publications, if you have detected but less than 15, it doesn't really influence the fact that these individuals are, in fact, on the way to cure. So it's just an issue we deal with, and I don't know if others deal with it, but we certainly do. You're not meant to read this. It's very similar to, again, what Chris put up. We offer a long litany of tests that you can do for this. The one thing this really brings from my mind is that we, as we think about this, as an organization, we don't want to look at this as being a test provider only, but a solutions provider to the clinician. So in this case, we don't want to only provide a test, but we want to be able to make it so it's palatable to the clinician to order the right tests. So what was said in the first series of talked about AASLD IDSA guidelines-driven testing. So we actually looked at that and pulled together test codes so that the primary provider, once they get a positive result, know that they have an infected individual. What are the baseline tests? What are the monitoring tests? What are the cure tests that you should do as a single test code? So we went through all the guidelines and pulled them together so you can order a single test code to get that data. So it's not just a matter of RNA testing or resistance testing, but these are the individuals that need to have linkage to care, and it's easier as a primary care provider to get the appropriate tests if they send them on to hepatology, as an example, to get their further care if it's a complicated case, to go with the appropriate baseline testing for them so they don't have to repeat it. The other thing is, I know that Susan Hariri is going to follow the three of us talking, and it's going to be important for her to actually talk a little bit about how the organization, CDC, is working with commercial organizations like ours in testing. And we do have a very strong relationship to take our data sets and work with John and his team, John Ward and his team, and Salim and Scott, to actually take this and look at it and see how it best fits in for defining women who are pregnant, prison systems, people who are dealing with liver fibrosis at the time of diagnosis, and what the category they are in at the time they're diagnosed. And the data sets really accomplish that in some way. We also we think of ourselves as partners with the CDC. So the partnership is really not just in testing and the algorithm and looking how we can accomplish everything, but it's also in communicating, again, as was stated by LabCorp, is that we link to try to get the communication out. So we're developing our campaigns in concert with what the CDC is doing. So relative to just being repetitious, and there's nothing really wrong with repetition, it's really a matter of trying to get this to the point where we complement what the CDC is doing in a very positive way. Fill in gaps. Try to actually accelerate getting people into testing and then getting them into access to care. And that's the end. And I finished 1 minute and 17 seconds early. Thanks.
Thanks, Rick, very much for finishing early. I'm very glad to see that today we have a representative from clinical laboratories here, as well as commercial laboratories. A very old friend of mine, Belinda Yen-Lieberman, who I think will be one of the most entertaining speakers of this morning, if I had any experience with her in the past. She's a professor of pathology and heads up the labs at Cleveland Clinic. Belinda?
Sorry. I get 1 extra minute.
I told you.
I don't have a pocket. I hold them.
Okay, that works.
Okay. So I want to compare with the giant, the LabCorp Quest. I'm a little potato here. I want to first acknowledge I worked together with our primary care chair and then 2 hepatologists. So some of the data I use from them. Without them, I would not be here. So again, I very simple. I want to go through with you briefly the test practice and test platform, much more simple than Quest and LabCorp. And then mostly I want to concentrate on challenges we face at the Cleveland Clinic implementing the HCV screen. So this is our hospital. We have 1,300 beds. We have a small reference lab. However, it's like business. The Cleveland Clinic also has 18 outpatient clinics, surgical center, also a regional hospital. The main thing is that for until now, all the molecular tests or high volume tests, all triage performed in the core lab. So I'm at the core lab. And to make things easy for me to give you an example, I'm going to use, I have numbers from 2015, so I can give you some number about our screening, what do we have. So I'm just illustrating everything, use the 2015 number. So for year 2015, my little lab did 69,000 tests per year. This is the tradition algorithm, been director for 24 years. So we received the sample, and the doctor ordered that we will do the test. When the antibody test is Hep C positive, it automatically reflects to HCV quant. And once in a while we have a shortage sample, we ask for redraw. And if HCV RNA positive, and then it's going to reflect HCV genotype, this goes to the hepatologist. They're the one going to order genotype. At the very beginning, because a lot of people order HCV quant to monitor patient, they don't need to do genotype every time. So we want to give to the hepatologist since they follow the patient. If it's negative, and we do not follow up. So here are some numbers. So testing algorithm for screening and diagnosis of Hep C at the Cleveland Clinic, the year 2015, we did 69,000. Of the 69,000, 3,623 were HCV positive. So it has a 5.2% positive rate. Now this is for all the anybody we receive. HCV RNA quant is about 11,000, so a much smaller lab. And then we use HCV genotype with subtype, it's only 1,200. So quickly, this is since I'm the only one showing the machine, I'm the only one working in the lab. And this is our I-2000 architect, and this is our immunology lab. This is what we call the CAPTAC, it means Cobas, Amplicret, and TechMan. It's from Roche, it's automated. And then, of course, we use the same HCV gene marks, HCV electronic sensor genotype using the XT8. Okay, so here comes to me, the heart of the presentation is what did we do to follow the guideline, the CDC's HCV recommendation. So 2014, the Institute of Medicine formed a group. The group is going to use the electronic medical record to provide reminders and other tools the EMR can do to promote evidence-based, national approved screening and surveillance program. And HCV screening is one of them. And our second one is the cervical cancer. That's a different subject. So it's headed by Steve Hayden. So what they did was they implement the program in the electronic record. So it's called, the program is called Epic Health Maintenance Alert, and then August 2014. So the program in the Epic, first thing would be the birth year, automatically will flash out. And the Epic Alert is routinely addressed by primary care physician mainly. We try to eat ED, but it's not so efficient because they are running crazy and they don't care what I'm doing. So the primary care physician all trained and follow the alert. So this started in August. So at the beginning, they were really worried there are going to be so many baby boomers, right? So they said, let's just increase the age by 5 years each few months. So you can see we started August 14. By June 2015, we complete the 20-year, the baby boomer year. And then everyone said, oh, we're okay. So that's when the whole thing started. So we do follow the CDC, USPF, SDF recommendation. So for example, a patient come in to see you. The patient sit down, give them the name, they're gonna give you a birthday. And then right away, the computer said, was the patient born in this year? If the answer is yes, second question, has the patient had Hep C testing recorded the EMR? So this is in front of the primary care. If it's yes, we know they no longer need a reminder. And if it's no, there's a smart order set right away will in order Hep C antibody, automatic reflex, the confirmatory. So if the FC antibody negative, stop right there. If the RNA, Hep C RNA is negative, stop. If Hep C antibody positive, HCV RNA also positive, and then sent to hepatology for further assessment. I want to mention here, when the Hep C is positive, RNA is negative, it goes out as observation follow through. So it's not in this algorithm, but the hepatologists follow through them. So quickly, if they're both positive, it's sent to hepatology for further assessment. Sometimes to speed up the process, the primary care doctor will click on the Hep C genotype. So by the time patient referred to the hepatology and clinic assessment, they use FibroScan, and that is FibroScan is performed in the hepatology department. And for the fibrosis, possible liver biopsy or observation versus antiviral treatment. Remember, we only been doing this for 1 year. So I want the data. I was desperate data, so I met with this group, very mannered internal medicine. I said, well, where's the data? I need to give some data. CDC said, we don't have it. This is the Medicine Institute research that we need the IRB, we need the chart review. I said, forget it. So I went back to lab. I talked to the laboratory, LIS, laboratory, we have our own laboratory information system. At least when I come here, I promised Celine I show you some data, right? So I asked the, pathology, we have an Ultrasoft, it's computer software. I said, in the year of 2015, I know 69,000 tests performed. How many of them is in the baby boom age? She gave me back 47,000. This is 68.3% of the total number sample we tested. They all belong to baby boomer. And then how many of them are really positive for antibody is 2,200. And when I check with the hepatitis, I think you're in the right range. I have no idea. They were really worried. It's real high. The population of patients come, I joke with them. I said, well, they come here have an open heart. I don't think they're going to have all this. So I was more optimistic they're not going to be bombed out. But so 2,200 positive for the HCV antibody. So this is my last slide. And then, so when I sit down with my hepatologist, with one primary care, I said, well, I'm going to give some summary, my last slide at CDC, and then I want to get your feeling. And then, of course, all of us we're old. We're all 65, gray hair. So I said, what do you think, Dr. Barnes? He said, the one thing they change is a primary care patient see primary care, and they get the hepatology have to be referred. So right now, they automatically refer anyone comes in with hep C disease or similar. So we are more than willing to see our patient with HC disease, and then we feel very positive everyone will eventually be treated. I'm talking about the Cleveland Clinic Network, right? And eventually, what he's happy is the hepatologist really, really bogged down with liver transplant. And so hep C will no longer be the leading cause of the liver transplant. And he looked at me, he said, look, Belinda, in my lifetime, I never dreamed this is going to happen. He said, I've seen patients the last many years, 95% of my patients, they are in remission. And I got to see this where I'm still working. So he had a big smile, and they're very optimistic. So I was very happy to know that we're doing the right thing. That's the end of the presentation. Thank you very much. Any questions?
Thank you. We'll go ahead with our final speaker, who is Dr. Susan Hariri from the Division of Viral Hepatitis at CDC. And she'll be speaking specifically on using some of these commercial lab data for the good of the public health.
Hi, everyone. Oops. How do I advance this? Sorry. Enter? Okay, got it. So as we have heard all morning, as you all well know, there have been advances in treatment, and in particular drugs that can cure 95% or more of hepatitis C. And this has provided unprecedented opportunities for us to actually prevent the consequences of viral hepatitis through primary and secondary prevention. But in order to do that, again, as you heard, we really need to develop improved methods and auxiliary data sources that can supplement surveillance data in order to be able to target prevention efforts and be able to evaluate the success of the efforts to prevent viral hepatitis. So to that end, our Division of Viral Hepatitis, is working with two of the largest national labs, which you just heard from, Quest and LabCorp, to get data on all viral hepatitis tests. So that includes A, B, C, and E in the case of Quest. LabCorp doesn't do E testing. And the tests include all screening and confirmatory tests, molecular tests, genotyping, viral load, as well as serologic tests to assess liver function and also biomarkers of disease staging, liver disease stage. We also get patient-level data, and we get a limited amount of information on demographics and geographic characteristics of the patients. We also get ICD codes that are associated with the test. We also get some information on the providers who ordered the test so that we can monitor those trends over time. We get specialty of the provider and location of the provider. And then finally, we get aggregate data on testing volume, and this is really important because we get this so that we can normalize and account for the fluctuations in the market share that the labs have in order to be able to better interpret our trends over time. So we use the lab data in a variety of ways, and this applies to all viral hepatitis, but I'm going to focus on HCV in this case. We use it to characterize the burden of hepatitis at national, state, and local levels, to monitor temporal trends in testing and positivity and in provider characteristics, to evaluate the impact of various guidelines, recommendations, policies, and interventions, and also to examine the burden of hepatitis C in key subgroups. For example, in the people who are incarcerated, in pregnant women, in baby boomers, and so on. So just to give you a sense of the scale and the volume of testing that we get, this is just for 1 year of data, and this is HCV testing only. In 2015, we got about 4 million HCV-related tests from Quest, and similar, about almost 3.5 million from LabCorp. And this represents all geographic, all 50 states, DC, Puerto Rico, and the Virgin Islands. However, there's wide variability in coverage across the states, and it can range from as little as only 120 tests for a given state in 2015, up to almost 750,000 tests in other states. And the labs also assign unique patient IDs using personal identifiers. We don't get that at CDC, but the labs use algorithms to assign unique patient IDs so that when we get the data, we can deduplicate and do person-level analyses. So we have about 2.5 million unique patients that are represented for 2015 in Quest and LabCorp. And then one thing that's important to note is that this doesn't mean that we have information on 5.3 million people, because there's quite a bit of overlap. We know that people get tested and they have their different tests sent to different labs. And one big limitation that we have right now, and we're trying to sort of come up with creative solutions for, is how to link people across the two labs. So right now, most of the analyses that we do, we look at the lab data separately. Another thing to note is that not all of the records can be linked to a patient, so we have to exclude, for person-level analysis, about 20% of the data from Quest and about 5% from LabCorp. Okay, so I'm going to show you just kind of an assortment of results and data and graphs that we're working on. I just want to say these are preliminary results. Most of them have not been published, and they're at different stages of development. So I'm just going to show you these kind of as an illustration of some of the ways that we look at the data. So this graph shows the rates of HCV antibody testing among patients that are served by Quest in the solid lines since 2011, and by LabCorp in the dashed lines since 2012. And this is through 2015. And it's in two groups. The baby boomers born from 45 to 65 that are represented in the purple here, and young people under 30 years of age at the time of testing, which are represented in the blue. So as you can see, testing did increase after the screening recommendations. Again, CDC recommended one-time testing in boomers in 2012, followed by the USPSTF in 2013. And you can see here in both labs, the testing went up in 2012, 2013, and 2014 after the publication of the screening recommendations. And we can see now that it seems that there's a little bit of a leveling off of testing. We need more years of data, of course, to be able to really look at that. But it's definitely leveling off at a level that is well below what we would like it to be. So it's about 3 to 4% testing annually in the baby boomers. For the younger population, the rate of testing is actually higher consistently across all years. And it's been going up, probably reflecting the increase in injection of prescription opioids and heroin. And that's true for both labs as well. So this is the same data over the same period of time, but here what we see is the percent that are HCV antibody positive among those who had an antibody test. And again, the purple are baby boomers, and you can see that not unexpectedly, there was some dip in the proportion of positives after the screening recommendations, but that leveled off at about 10%, which is still well above that of the younger age group, but which is down here at the bottom in the blue. You can see there's about 2% antibody positivity, but you can see that it's increased over time, which is consistent with what our surveillance data show. So switching to analysis looking at geographic burden and geographic distribution of HCV. This is a map of HCV RNA rates among persons that are served by Quest and LabCorp. And depending on the coverage of the lab in any given state, we use either LabCorp or Quest in this map. So you can see that there's a pretty high burden in the Appalachian region, Ohio, New Mexico, California, and Alaska. This is consistent with what we know about the burden of disease. And I'm glad Chris put this up as one of his slides, but you can see that there are several states in the upper Midwest and the Northwest that where we suppress the data because the coverage is low for both labs. So this is less than 10% coverage in those states. This map shows the number of people who are between the ages of 15 and 29 who had a positive HCV RNA test. And this is mapped by zip code. So each dot on this map represents one person. And you can see again, just like we saw in the previous graph, there's a lot of RNA positive cases in the Appalachian region, in Florida and in California. We can't really speak too much about what's going on in the upper Midwest because we don't have data. It's possible that there are more cases and we're just not capturing them in these two data sources. So moving on, we're doing analyses of key subpopulations. This graph shows data from state correctional facilities, and this is data from LabCorp, but we're also working to look at this in the Quest data as well. And this is the proportion of antibody positive people who are incarcerated in state correctional facilities by state. So the first two states in yellow are those that do universal testing on intake. Those are Nebraska and Colorado. And you can see that the prevalence, even with universal screening, is higher than 10% and approaching 20% in Colorado. And then the rest are prevalences by state for those that do risk-based testing, and that ranges anywhere from about 15% in Nevada to up to approaching 50% in West Virginia, which is pretty staggering. This is just some data that I pulled out from the MMWR that was published looking at trends in HCV detection in women of childbearing age. This is data from Kentucky, and you can see the dramatic increase in HCV detection in women in that state from 2011 to 2015. There was a 270% increase in HCV in women, and we're actually currently looking at the same thing in pregnant women and in children. We also produce extensive detailed reports at the state level that we share with all of our viral hepatitis coordinators at the state to help them with their prevention efforts locally. And basically, a lot of the data that I just showed you, we share with the states on HCV antibody and RNA testing and positivity, and we give them tables by quarter, by demographic characteristics, and also give them maps at the county level to help them to identify hotspots of disease. These data are hot off the presses, and I just wanted to show this because I think that the audience here will appreciate. We're looking at the viral load distribution sort of the population overall. So these histograms basically show viral load distribution in everyone by lab, so Quest and LabCorp, and you can see that the median is 6 logs, so it's about 1 million international units. This is in log 10 units. And it's skewed to the right, so the viral load appears to be pretty high, and this is really helpful for developing antigen tests and determining the limits of detection for testing. And we're now looking at viral load by different characteristics. So for example, we're looking at differences by gender, by age, in viral load distribution, and we're also looking at this by genotype and other clinical characteristics. So these are great data, and we're delighted to be able to actually use them, but there are some challenges, and one is that with the massive volume of data that we get, the cleaning and the QC and the data management is a huge undertaking. And we've spent quite a lot of time with our lab colleagues sort of in an iterative process, making sure that the data are complete. We've identified, coding errors that have resulted in missing data that requires going back and forth. And so, standardizing the results of the lab tests and being able to interpret them and so on is very cumbersome and time-consuming. Identifying subpopulations, likewise, using the account names, it takes a lot of work, for example, to identify correctional facilities by just using the name of the account from the lab data. And same thing with classifying certain variables like payers and providers. For example, Medicaid managed care is lumped with private payers in the lab data, so we have to tease that apart, and that takes quite a bit of work and resources to do. Now, these are all tractable problems.
Excuse me, Susan. Wrap up.
Oh, okay. Sorry. Okay, so the one thing I want to mention is that we're unable to link across across labs, and this is something that is going to require some creative thinking on our parts to be able to do that so that we can follow people longitudinally and monitor the care cascade in cohorts of people. And I guess I can stop there. I just have a summary slide. The commercial lab data are a hugely valuable resource for guiding public health action. They provide timely reporting, large volumes for subpopulation analysis, wide geographic coverage, and we're using them to describe and monitor the epi of viral hepatitis over time and hopefully evaluate the real-world impact of our policies and guidelines. And I'd like to acknowledge all of my colleagues at CDC, Quest, and LabCorp who participate in these projects. Thanks.
Thanks. We're up against lunch next, so we have about 20 minutes, I think. We can open it up for questions for anybody on the panel. As I mentioned, you can either go to the microphones that were there, or you do have microphones on your desk that you just need to press in order to ask some questions. I would actually like to start off because we've had a lot of information from commercial and clinical laboratories, and no one has talked about cost and reimbursement. And I'm just wondering if we can get some sense of what an antibody test costs and what RNA test costs and what the experience has been with billing and reimbursement for these.
I actually don't know cost of testing, and it varies a lot depending on where you submit it and what providers. I would say it was a question when we moved to a reflex-only environment, but we haven't had an issue associated with that. There are challenges from the standpoint of some environments that don't have internal funding to do the nucleic acids testing. They only have funding to do antibody screening. And so from that standpoint, they have enough money to pay for antibody and then refer out NAT testing. So that's a challenging environment. But from a third-party payer environment, in general, we haven't had challenges with that.
Of course, I don't know the cost, but do you know the reimbursement? That's what a good place to start. Reimbursement is mostly known, but all I know a long time ago, when I cost out a long time ago, Hep C RNA, if the company charged me $85 to buy the test, and then I have to do a positive negative control, I do daily IQ first thing. By the time I finish, I cost out the test, let's say $150 because 30% overhead. By the time I send to the people in charge of the cost, they can come back like $350, and I'm going, what happened? But so because I don't know the market price, I don't know the QA, QC, the electricity, the air conditioning, the technician, and then that's, I didn't learn that in school, so I can see why something we cost out in the lab, it was $150, it became $3. So like Rick said, we have no clue. I always want to know what's the reimbursement.
Yeah, of course. Let me add one quick comment that the idea to go to payers with a reflex test as a standalone, as the only one, is always a challenge as well. That's where the partnership with the CDC and with USPSTF and a variety of other organizations and healthcare providers in general who have lended support into that idea, we've been able to actually go to payers and say this is medically the right thing to do, and that has resonated. It doesn't always, but in this case it helped.
Rick, just on that, I want to mention that in the U.S. Preventive Services Task Force recommendation, the HIV antibody with the RNA tests are considered the screen, so that for programs that are under the Affordable Care Act, they should be covering that without any kind of cost sharing. I think John had his hand up.
Thank you all. Those are great presentations. I want to thank the laboratories represented for helping us promote Hep C testing through education, clinical decision tools, and through the reflex becoming the standard for Quest. And it's really very, very helpful as demonstrated by the data that Susan showed. So I have two questions. One, for Quest and LabCorp, maybe even for Cleveland Clinic, what's the churn in your system? What percent of facilities are in the system 1 year and then using another laboratory service provider the next year, just so we could get some sense of the consistency of the data from year to year. And then number two, as we began to have data shared with us from commercial labs, I really was very impressed with the breadth of that information, particularly regarding the provider type and ICD-9 codes and stuff, and just don't see that in surveillance data. Now, some of that may be a capacity issue. I'm just interested also, and maybe Jeff can comment on this, or others of the states represented, does that information get traditionally shared from commercial laboratories, or because of the way mandates are written, it's a very narrow slice of that information, just that antibody or PCR test versus this other data that Susan showed examples of. So some question about the system changes from year to year, and then some description of what type of data is being shared between commercial laboratories and public health systems. Thank you.
I'm sorry, but it's not uncommon that an account would go to another lab. It happens pretty frequently, and there are a number of drivers for that. So I think, yeah, there is certainly many opportunities for a patient to be in one lab one year and in another lab the next year.
Yeah, and I would say sometimes it's even large groups. So there is a level of consistency sometimes when a very large payer group has a contract with either Quest or LabCorp. In that situation, they would have a contract for 10 years, and then the contract would come up for bid, and it can change. So you can have a level of consistency for a number of years, and then it can change. So in some of those healthcare third-party payers that the organizations have actually are extremely restrictive. So from the good standpoint, they stay with that provider group and they're captured with that lab. They don't normally go out of network because they're really not allowed to go out of network. But the smaller ones, you never know.
Before we get to the audience, I'm going to take the moderator's prerogative and ask a corollary question to Dr. Ward and ask our laboratorians, when you get a lab result that's reportable in a specific jurisdiction, how do you get that information to that jurisdiction in a timely way?
There are some requirements for reporting. Again, I'm not that familiar with that, but the systems are in place to compile the data on a periodic basis. It could be quarterly or annually, and you report the data. But it could be very specific to
so
where.
I'm talking if you get a test result that you give to the provider, you should be giving also to the state at the same time. Do you have that capacity?
Yeah, they're built. They're absolutely built-in systems for doing this, like Chris said.
We do the same.
Yeah, any lab that has state requirements, if you test in a state that has state requirements, it's automatically done. I'd say the most current issue that we're dealing with is Zika. So, yes, all of these things are built in. Now, the question comes in, we as a lab would like to send an HL7 data stream, but not every public health department has the ability to take in electronic reporting in that way. Many do, but not everyone. So we also have to look at what the capabilities of the public health labs are for taking in the data. Do we do it manually? How do we do that? But we always adhere to the requirement of the state.
Great, and we are certainly working to build that HL7 capacity nationally, so we agree with you there. Yeah. So, at the mic.
Hi, Ann. Hello? Hello? Okay. I'm Ann Gaynor from APHL, and I agree that we are trying to build lab capacity for electronic messaging. But my question was to Susan, I guess the whole group. You had mentioned the lack of standardized reporting. This is something we've dealt with in the HIV realm as well, and have been a lot of discussions lately about LOINC codes and SNOMED codes and all those coding to standardize. And just curious where things stand in the HCV world, if that's something on the horizon or not.
Well, I don't know about the sort of systemic standardization of LOINC codes, but what I was really speaking of is we get the results of, for example, the molecular tests in different units. And it's not necessarily indicated whether it's a log unit or not. So, we have a value of 8. We don't really know if that's 8 log or if it's 8 units, international units. So there are those things that we mostly deal with in trying to standardize the results in a way to interpret them. if you guys want to.
Yeah, maybe something that would help clarify. So in the diagnostic business, and this is something I learned. So there was a period of expansion, and you expand your territories by basically acquiring other labs and other, you can basically buy your clientele by buying your competitor. So that happens quite a bit, and so depending on where an assay is brought up or developed, and the systems that support it, there can be different ways that the data is captured and stored. So one would like to think that you could just go to a common database and have everything in a standard format, and it's not like that. It's cobbled together. I mean, there are very large bioinformatic efforts to get to that point, but it's not easy to do. So.
Yeah, I guess just as a follow-up real quick, I would just say that, there was mention earlier in the earlier session about sort of trying to build these sort of more robust networks and reporting and that kind of thing, and those considerations I think are certainly important before all of those get way out of control.
I have a question about genotype testing. So you mentioned that certain tests have kind of come in and out of favor over time, like IL-28B or Q80K, and I'm just wondering, now that we have a pangenotypic agent, what you see the future of genotype testing is. I know it's still in the guidelines to do genotype testing, and I wonder if and when that might change.
Every week I see the NS34A sequencing results, and I'm curious who's ordering them. But they still come in. So it peaked, and then with some other drugs coming on board, that it fell off, but it only fell off 50%. So I find that interesting. There are a number of clinicians, for one reason or another, that continue to order. NS5A testing is still very strong, and that's probably driven by Zepatier, and that may kind of go away with Epclusa, but that's why one of my points was, how do you gauge and predict? It's somewhat unusual.
And I would only add that it's an assumption that the few pangenotypic that we have are going to be totally adopted and surpass every other drug. And as you know, a lot of these drugs have financial considerations to those that are using it in payer groups, and there's going to be a pricing war, I suspect, to get utilization of drugs, and so those drugs that still have in their label to do genotype testing up front will continue. I think it will be a progression, a slow progression. It's clearly the wave of the future in my brain is pangenotypic, but it may not be for every case in every situation. So I think there'll be a drive, and you'll see, as Chris said, you'll see a change, maybe a decrease, but it's not going to go to nothing.
Yeah, quickly talking to our hepatologist, he agreed. You will notice the genotype requests will go down because Harvoni, all the drugs will take one. He said, realistically, many years from now, maybe we don't even know the genotype because there are 7, 10, 11 drugs. I get a response from our hepatologist, like you said.
So I think we have no more. We have 3 more questions. So we'll take them all, but if you can be brief, like less than 1 minute, same with the answers, and then we'll break for lunch. Thank you.
Okay, thank you. Just from the public health perspective, I want to thank you all who are doing reflex testing, because that's not available through all commercial labs, believe it or not. So that's huge. Also, would encourage you guys to continue to move forward with meaningful use and the electronic lab reporting, because from a public health perspective, it's a huge burden with the labs that we get that are manually entered. And then in terms of the power of this data, we definitely appreciate and digest the reports that we get. But again, from a public health perspective, it seems like a workaround. If we get the money to actually do the surveillance, we get the patient information, we can do the deduplication, we can trigger case investigation, look at outbreaks. These are obviously people who are just tested to and ultimately use the information longitudinally to develop cascade of care or data to care. So obviously very powerful data. Thank you for sharing and moving it towards us, but just another plug for the ability to use it locally.
Sorry, I'm off. That was one of my comments too, is to ask Susan if there's something on the horizon to allow the state or local jurisdictions to actually access the data, even if it's a de-identified, more aggregated set of data, so that we can do some of that work ourselves, because that is one of our needs. That I mean, the reports are great, but it would be really nice to actually see the data ourselves. So that was one question, and just on the cost issue that came up. So we contract with LabCorp to do our confirmation testing, and it's $161 a test for the confirmation testing. We only had 131 positives through our state lab, and that was $21,000. And our total cost for just 6 months this year was $107,000 for the tests we're doing. So that's a huge issue for us, is how do you find the funding for that kind of stuff. So Susan, if you have any comments on that, on that first part.
Sure. So we actually spent a lot of time getting feedback and input from the viral hepatitis coordinators in developing these reports, and these are sort of, dynamic reports. And as needs arise and as we get requests, we're certainly accommodating to that, and we'll be able to work with you to get you the data that you need, depending on what the situation is. So yeah, I mean, I think we have to sort of do it on a case-by-case basis, and as things come up. Yeah.
I noticed that both the Cleveland Clinic and Grady here in Atlanta trigger the testing process by a clinical reminder. I'm curious to what degree the clinician actually asks the patient for consent to do the test, and to what degree patients agree, et cetera?
When I asked the question to our primary care, when the first patient came in, when he spoke to the patient, he said that's patient consent. He doesn't have to sign anything.
Right.
Yeah, at all. And just like the HIV, when the clinic, we used to sign, no longer increase the efficiency. The doctor knows better for her, his patient, therefore it is. That's what I was told, yeah.
Okay. But do patients decline?
No, not at all. Actually, the number of HCV screening has gone up. Mm-hmm. Yeah.
Yeah, so we do it in an opt-out fashion as well. So we try to train providers to give the message, we're going to test you for hepatitis C today, tell us if you don't want to do that. And anecdotally, there aren't a lot of decliners. However, I will say that from our navigator's perspective, she does say that often she'll call the patient with the results and they say, my doctor never ordered that test. So I think the communication isn't happening in every instance.
That have looked at that issue, and the proportion of patients who think they were tested and weren't is about the same as the proportion of patients who were tested and didn't know it, and so it goes in both directions. I know we're about to head off for lunch. I need to remind people that we are in a U.S. government facility, and so if you want to go to the CDC cafeteria, where you're welcome to, if you don't have an ID badge, you need to be escorted by someone who's an employee. There are volunteers waiting outside, volunteer escort service from CDC, and I would like to finish with one last question, is that it's a wonderful thing to be able to do reflex, but what does that do to specimen handling requirements? And do you have people send one tube? Do they have to send 2 tubes? How does that work out?
Yeah, no, it's off the same tube. That's the advantage. The antibody is tested. If it's positive, they go back to the same source and do the reflex test. Single tube.
But because some of the processing for RNA or genotype, for example, requires that it be removed from the cells, does that change what people have to do?
No.
Yeah.
But it's more stringent.
Yes.
They're the same.
Yeah. So you go to the more stringent requirement in order to process.
So it's more stringent for the reflex than it would be just
correct.
for the antibody.
That's correct. That's
We have
correct.
no problem. Yeah. Same.
Great. Thanks very much for everybody on the panel. We had a very interesting session.